Check, check, 1, 2. Check, check, 1, 2. Check, 1, 2. Check, check, 1, 2. One, two, 1, 2.
So you got to give it a couple of beats so it establishes its.
Check, 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 check. Hello, hello, hello.
Yeah.
Okay.
streaming it where?
It's not our YouTube channel. Okay, so you'll be actually okay. Put it right there, and when you're ready, you just flip that. Wait a minute. Yeah, it's live.
Okay, testing. Everybody hear me? That's good? Okay. Well, welcome to everybody to the CMC Mini Medical School. This has been going on for many years. I've participated in some before. This is the first time as a moderator. I'm covering for Dr. Dan Foster, who usually does this and can't be here. And we'd like to give special thanks to the CAMC Foundation and the Cancer Center for providing support. I guess we are going to be on YouTube, so everyone smile. And we have 4 really great speakers today. As mentioned, the subject is cancer. And our first speaker, I guess I'll introduce people as they come up. The first is Dr. Sandeep Kashyap, who has multiple very impressive academic credentials. I think relevant to this, he's board-certified thoracic surgeon and general surgeon, has done a fellowship in minimally invasive thoracic surgery, especially in robotic surgery, particularly in treatment of thoracic malignancies. And one thing I found very intriguing reading his curriculum vitae is he has certifications in artificial intelligence in healthcare. So maybe we can ask him questions about that, how that applies to cancer treatment. So, Dr. Kashyap.
Thank you, guys. Can you hear me? Let's get this mic working. Great. Okay. All right. Thank you. So, kind introduction, and so excited to be here, and really happy to be part of this mini medical school, especially public facing, and because we need to talk about cancer and all that affects us here at West Virginia. So let's talk about taking control of lung health in West Virginia. I wanted to kind of start with saying who we are. All of us who are cardiothoracic surgeons, in that special group, we specialize in what we call general thoracic surgery or thoracic surgery, where Dr. Herrera and I, do thoracic and esophageal surgery in a minimally invasive technique, and that's our department there. And we practice, our scope includes anything that's in the chest that's non-cardiac. We don't do transplants, but we do cancer of the esophagus, lung, mediastinum, and the mediastinum is like at the center of the chest. It has the thymus and also the chest wall. And talking about lung cancer, why do we need to talk about it? We all know that it's prevalent, but not many people know that it's still the #1 cancer killer in the US. Lung cancer kills more people worldwide than any other cancer type. And every 2 minutes, they say someone's diagnosed with lung cancer. 1 in 16 Americans will be diagnosed with lung cancer in their lifetime. And I would say that we're not far from anyone, either someone in our family, our friend circle, who either smokes, secondhand smokes, or has lung cancer. So another statistic that, when I learned was kind of interesting is lung cancer actually kills more people than breast, prostate, and colorectal cancer combined. That is more women than breast, colorectal cancer and ovarian cancer combined. And there are more lung cancer deaths in men than prostate, colorectal, and pancreatic cancer combined. So, that it really drives home the point that we need to talk about this. We need to really understand the state of lung cancer in West Virginia. It needs work. We are among one of the states which has the highest smoking population, and the early diagnosis needs a lot of work. There is the survival. You can see we are at the 40th of the 47 states that we have the data from, and but not all of it is bad. This is a slide that I recently found in one of the presentations, and I wanted to put it up because this was the first time with the cancer statistics in 2025. I can go back and say that lung cancer no longer was, in this latest statistics, the number one cancer killer. Okay, it has finally got off that, and the cancer mortality is coming down. And, but interestingly, more women are being diagnosed with lung cancer now compared to men, because I think it's just being picked up a lot more in non-smokers. So this can definitely change, even though it hasn't changed in West Virginia and majority of the states, it definitely can change. Why is it such a big killer? Because there were limited options for treatment. All right, when in the 90s there was just chemotherapy, majority was being found in stage 4, and there was not much we could do, and it was almost considered to be a death sentence. But it's not like that anymore. It's not a single disease. Now we know that lung cancer is a spectrum. It's a molecular-based disease. We divide it into small cell, non-small cell. Small cell, again, is a spectrum of neuroendocrine tumors. It has different gradations to it. In the non-small cell, we thought histologically, when you look at it under the microscope, it's either squamous or non-squamous or adenocarcinoma. But it's not like that anymore because we know so much more about the molecular origin of the lung cancer. And we have treatments that can specifically target a lot of mutations that we know. And we can give these treatments not only in late-stage lung cancer, we have brought these treatments to early-stage lung cancer where many patients who were initially thought to be not surgical candidates, we give them treatments to make their cancer shrink, and they would potentially be candidates where they can undergo surgical resection. So one of the key points that has helped improve lung cancer survival is finding it at an early stage. If we find it at an early stage, we can achieve a cure rate of close to 80 to 90%. It's still not 100%, but that I'm talking about 5 years. We're now starting to talk about a 10-year survival rate that was not heard of in lung cancer. Lung cancer screening is one of the tests that is a CT scan. There are a lot of ways that people thought about screening for lung cancer, and we're still thinking about it, with the blood test, with a test from an inhaled breathing test, a salivary test. But the only thing that stood the test of time and has proven by a study that was randomized and was done at the Leahy Cancer Center and was published in the New England Journal of Medicine was the NLST, where they compared lung cancer screening done via CT, which is an annual low-dose lung cancer CT compared to chest X-ray. This was the only test that proved that there was an 80% reduction in mortality if we caught lung cancer early. Lung cancer screening is covered by insurance, and there are a lot of different recommendations, but the most common recommendation that we use and everyone should know and recommend people that that they undergo screening if they're between 50 to 80 years old, if they have a 20-pack year of smoking, and if they're current or former smoker in the last 15 years. There are a lot of updates coming to this where it's very difficult to exactly calculate pack years. So with the NCCN, which you guys are familiar, is coming up with new guidelines where we don't necessarily have to have a specific pack year. So, but still, for insurance purposes, this is what we use. And we need to make an impact at each level. Where we are struggling with is in prevention, management of incidental lung nodules. Then comes the low-dose screening. We need help from the community. We need help from the primary care doctors. We need help from all the other physicians and the navigators, and so that we can get these patients at an early stage to the treatment pathway where they can undergo appropriate treatment, either a surgical resection or chemotherapy or immunotherapy, whatever need be. So this is something that I want to put up and say that what happens, okay, if there's someone who doesn't really know and wants to know what happens after lung cancer screening, right? After lung cancer screening, the most common thing that happens is you get a letter saying, congratulations that you've done well on your screening. There's nothing more that needs to be done. You're going to make sure you get a scan the next year. But many times what we want to catch is these small nodules, these small spots, and many times when you find spots on the lung, that doesn't necessarily mean cancer. So there are different algorithms and pathways, and they grade the cancers, the radiologists do, and they give it a grading. And depending on what the grading is, it kind of funnels into a pathway where our multidisciplinary team with our navigator here looks at it and says, oh, what needs to be done with this lesion? So this is important because previously we used to go after these large lesions which looked like, described as a grapefruit, an orange, a golf ball. But right now we are going for these small lesions and trying to take them out and find out if it's cancer or not. So we're not going for those lesions anymore. We're going for the Cheerios, as we call it. Like, we are looking at really small lesions and trying to take out, at an early stage. So if we find a lesion like this and it looks suspicious, the options are to either monitor it, to give it time, where if it grows in the next 3 to 6 months, then we know that it definitely needs to be addressed. Or the other option is to biopsy it. To biopsy it, there are a few ways we can biopsy it, and I'll show you a couple of different techniques that we use. And the other option is, to think about it in a way that we look at the whole picture and see if it needs to be surgically resected. So one of the ways of biopsying it, most commonly when you think about it, is a CT-guided biopsy, where the patient is asleep and the needle is from the skin, from the outside. That is done with our interventional radiologists. That has a pretty good diagnostic rate. The interventional radiologists here are fantastic. However, on the other hand, there is a newer technology that we use. It's called the robotic navigational bronchoscopy, done by us thoracic surgeons as some of the interventional pulmonologists, where once the patient is asleep, we can drive the small catheter using a control that's outside. It almost looks like a video game. And we use this to navigate to a small lesion that's there in the periphery of the lung or any part of the lung, and take samples. And after that, we are also able to sample the lymph nodes. And so all of that happens in the same setting, where many times we are even able to get a diagnosis. The pathologist looks at it right away and tells us if there's cancer or not, even though that's hard, but many times we are able to achieve that. And so if we do this in the same setting, this is, we get an ultrasound picture to make sure we've reached the lesion. And then if we do this, there are a few different things that can happen after. Okay, you get the result, you decide what kind of treatment you would qualify for, what your staging is. You usually get a PET scan where we see if it's spread to any of the lymph nodes or any other part of the body, and then decide. Let's say it's not spread to anywhere else, it's only localized to that one small lesion, then majority of the times you would qualify in stage 1 or even early stage 2, you'd qualify for surgery up front. There is no other treatment required. So the surgery involves for us to take a small portion of your lung. The less lung we take, the better the patient's going to do, especially in the population that we have. We have a lot of underlying lung disease already. We have a challenging population with a lot of granulomatous disease. asbestos exposure, coal mining exposure, which makes it very difficult. And they come in many times on oxygen, and their lungs are not really favorable for doing lung cancer surgery. But in spite of that, we are able to, with the help of the robotic technology, do lung sparing surgery, what we call a segmentectomy, instead of removing the whole lobe, or removing a lobe and not having to remove the whole lung. And sometimes do creative ways of putting the lung back together, even if you have to take more than a lobe out. So these are procedures that we offer. And the robotic technology has really come a long way. From the time I was training to last few years, we are lucky enough to have the newest version, which is called the DV5, which is arguably the best robotic technology available in the world. Now, there are multiple different companies coming up with better, but this is available here at CMC. And institution-wide, it's one of the leading programs that has adopted the DV5 technology institution-wide. So that's a really good achievement for CMC. And what it does is allows the surgeon to place instruments through small incisions, small trocars, and control it remotely, which gives 10 times the magnification, much higher precision, eliminates tremor, and allows us to operate on the patient as though we've made a bigger incision. The job on the inside, I always say, is the same, but it's just that we're able to access that through small incisions that makes the recovery much quicker, and we're able to do these more complex procedures with small incisions. And so this is an example of what we call a single anesthesia procedure, where I was able to use the robotic navigational bronchoscopy to go in and put a marker in the lesion that I want to take out. And this is on the robot, where we've put in Indocine in green, and it has a special camera built in where it actually shows me where the lesion is most likely. And then I was able to take only that part of the lung out as a mark, because the robot, believe it or not, in spite of all that, it doesn't have tactile feedback. We can't really know like a feel, but the visualization is so good that you actually, we say feel with your eyes. The newest version does have tactile feedback, but requires special instruments. So this is just a part of the lung that I was able to take out and find out if it had cancer or not, and the patient required a little bit more of a resection, which was completed by what we call a segmentectomy. So all of this is possible only if we get the patients to go to their screening appointments. And that's a challenge here, right? Like if I spoke to a patient today, and he said, Doc, you made me come in. I had done a thoracotomy on him. I thought, because he had chemoradiation and he had a large cancer which had undergone multiple treatments, and he had trouble coming for this appointment because he said he couldn't afford the ride, which was from 2 hours away. So and one of the biggest barriers that we've found for screening is for the person to actually reach it, and also to know that they need to do it. And the mobile lung cancer screening is exciting. WVU had it, and now we are complementing it with our bus. It's already working. So we're working with different communities and primary care practices to get this organized. So we're also doing a lot of different types of work to improve lung cancer care here. We got selected as part of a 5-member organization for early detection and diagnosis with the American Medical Group, and we meet monthly, and we are doing multiple quality improvement projects as a group to improve lung cancer screening uptake at CAMC. One of the biggest things that came up was the smoking history was not being accurately captured in our electronic health record, and we were missing close to 10,000 patients within our system, and so we are trying to fix that to get more patients within our system to be get qualified screening. And we are looking through our research team here through the Cancer Center, what the screening is per county and where the barriers are. One of the things that came up is the biggest barrier is someone actually telling them that this can be done and reminding them to keep the appointment. And many times it's hard for people to get over the stigma of smoking and actually say that this is something that can be cured. We're also looking at various other aspects of lung cancer screening CTs that can be used. The other biggest killer is coronary artery disease, and we're looking to see if we can combine those two things in the same scan. We've also collaborated with Mountains of Hope, which is another institution just like CMC Foundation, and to help improve lung cancer screening in the state. So all of this is happening as I was just talking with Monica that we've been wanting to start an incidental nodule program, which is where not only screening, but every patient who gets a CT scan, if the nodule is found, it needs to be looked at and followed up. And that for that, we are getting the help of AI and a software called EON, hopefully soon, and so that we can help people who have these incidental nodules, and also physicians would appreciate that as well. And artificial intelligence, this is kind of my new passion. And so in lung cancer, we are going to apply for a grant and hopefully get it to get a software that can do what is called a virtual nodule clinic, where if we get a nodule and pass it through the system, it is going to give us a score of how likely is this nodule going to be cancer or not. So it is trained on, close to 1 million scans, and from a pixel standpoint, it sees things that the human eye definitely can't see. It doesn't take away the judgment of the human, but it augments it and it adds to it. So these are the things that are happening here at CMC that's coming up. So we are here to help, and we appreciate the Cancer Center and all of you guys and what you're doing. And this 2 patients from this is actually from today. They just happened to be in my clinic, and one of the first one that you see was a patient that had sarcoma. It was liposarcoma was occupying his entire chest. Dr. Herrera helped me, and he's doing fantastic. The ones that I kind of want to highlight. Let me go back. If I think I kind of, let's see if this will take me there, but I wanted to highlight was one of the patients here. She was diagnosed with a nodule in her adrenal gland which is above the kidney. And they really didn't know what it was, and this was in 2020. And this patient here that I saw today. And in 2020, she underwent a laparoscopic adrenalectomy with Dr. Richmond, and they took the adrenal gland nodule out, and that came back as lung cancer. That means that lung cancer had spread to her adrenal gland, which kind of made it stage 4. At that time, her oncologist had given her 6 months to live. Okay, so then she switched oncologists, went to a different place. They gave her chemotherapy, and then they went back, looked at the pathology, and found out that her PD-L1, one of the immunotherapy markers, was high, and she got started on immunotherapy. So she finished chemotherapy and immunotherapy, and then she came to see me 5 years later, and the only spot that was still there lighting up was in the left upper lobe of her lung, and which we thought was the primary, which was missed at that time. And so I resected that primary and took out the lymph nodes in that area, and there was no evidence of cancer left. So she is 5 years out, completely disease-free, and she's 2 weeks out of surgery, and she is seeing me today. And this other gentleman here, he is one of the patients that had gone to a different institution with a small nodule, and that said it was too small to biopsy or too small to do anything about, which he didn't agree with. So he came to our practice, and he underwent a robotic navigational bronchoscopy, a biopsy, and it was early stage lung cancer. He underwent a segmentectomy. He came to see me. He was in 6 months follow-up. So these are regular, normal people who are, have lung cancer like a regular chronic disease now. It's like hypertension or diabetes. So we do have the technology, we have everything, and the patients inspire us. So, and we have a good team built up here, and we all get along pretty well and have fun. And we're happy to take care of your patients and answer any questions. It'll be after your questions. Okay. All right. Thank you.
Okay, thank you. That was fascinating talk. And I should have mentioned before, what we're going to do for questions is, if you have a question, remember it. And after all the presentations, we're going to hand out cards, and you can write down your questions. Then we'll collect them, and we'll ask the panel to answer these questions. Okay. Our next speaker is Dr. Argentos Herrera, who is also a board-certified thoracic surgeon and general surgeon, has had fellowships in both thoracic surgical oncology and minimally invasive thoracic surgery, and has a special interest in the esophagus, I've been told. So we'd like to welcome Dr. Herrera here, who's our next speaker.
All right. Can you guys hear me? Okay, very good. Well, thank you to the CMC Foundation and the Cancer Center for the opportunity to try to reach the community important topics in cancer. In my case, it will be esophageal cancer. So it's more of an overview. I'm not going to go into too much of technical details, but first of all, the esophagus is just, as I tell my patients, it's a muscular tube that connects the throat to the stomach, and it's just a conduit that has some functionality. The peristaltic move of the esophagus transports the food, and that's pretty much it. But what is important about it is that it's in the middle of the chest. It has the spine in the back. You can see the bronchi here on both sides, and the lungs are taken away. The big vessels and the trachea in front. The heart has been taken away also, but the esophagus is right behind the left atrium of the heart. So it's in the middle of all this, and this is important because, for the surgery, it makes the surgery a very complex one. Actually, I compare the esophagus and the thorax to the pancreas in the abdomen. It's like in the very middle of the cavity, and both surgeries are very complex and fascinating, I think. So the incidence is not as high as for lung cancer, but it's very lethal. That means that it's actually, in the US, is the 18th most common cancer, the most commonly diagnosed per year, but it's the 11th in total number of deaths. So out of 22,000 new cases in 2024, the estimated number of deaths was 16,000. So out of 100 patients that are diagnosed today with cancer, probably 80 will be dead in 5 years. And that hasn't changed in a long time. Worldwide, it's much more common, especially in the Middle East, where the Middle East has the highest rate of esophageal cancer in the world, but this is the type of squamous cell carcinoma, which is less common here in the US and in the Western world, but it's still common. And in West Virginia, the rate is actually above the average for the country. In the US, it's approximately 4.5 per 100,000 people. Here in West Virginia, it's about 5.9. It's around 140 new cases per year. But again, it's not as common, or the amount of deaths is not as high as in lung cancer, but it's very lethal. It's very, the amount of patients that are diagnosed, just a few ones survive at 5 years. What are the risk factors? They depend. There are two main types of lung cancer, esophageal cancer, squamous cell carcinoma and adenocarcinoma. Surprisingly, the adenocarcinoma incidence has increased significantly. Some numbers mention about 600% in the last 3 to 4 decades. And nobody exactly knows why. There are some theories and some studies showing that it's probably related to obesity and GERD, but it hasn't been 100% proven. But nowadays, squamous cell carcinoma and adenocarcinoma are very frequent, are the two most common types of esophageal cancer. The risk factors are, for the adenocarcinoma, GERD, Barrett's esophagus, which is I don't know if you guys have heard of that, it's a type of change that occurs in the esophagus from chronic GERD or gastroesophageal reflux disease, obesity, and smoking, which you can imagine those are very common risk factors basically in the whole country, in the whole in the US. Squamous cell carcinoma, alcohol consumption, smoking. Some studies show that a diet poor in vegetables and fruits, very hot drinks. Apparently, the Middle East, it's very common to have these hot drinks. And they have been shown that constant inflammatory changes from these drinks can increase the risk of squamous cell carcinoma, and a motility disorder of the esophagus, like achalasia, is another risk factor. Presentation. Unfortunately, esophageal cancer doesn't show many signs of in the early stages, and that's one of the reasons why it is so lethal. Usually when you have symptoms, it's usually at least locally advanced. The most common signs and symptoms, I would say that the most common and most specific is dysphagia. Dysphagia can be from many things, but a patient, I would say 60 years of age or more, male, that has dysphagia, you have to rule out an esophageal cancer. Other ways of presenting the esophageal cancer are unexplained weight loss, GI bleeds, anemia, chest pain or pressure. And when the cancer is advanced again, there are some complications like tracheoesophageal fistula or invasion of the trachea that can cause chronic cough, and metastatic disease can present like pleural effusions, many other ways. But as I said, usually when esophageal cancer causes dysphagia, it's at least locally advanced. Treatable, some chance of cure, but locally advanced. The diagnosis is not that difficult. An upper endoscopy and biopsies does it. You will be basically taking a look directly at the esophagus and the tumor. You take a biopsy that gives you the diagnosis, but there are some other steps for the treatment. And I wanted to bring up the Barrett's esophagus because trying to get in the talk about how to prevent this type of tumor, unfortunately, for esophageal cancer, there is no screening method that has been proven to be effective. There is a program for gastric cancer screening in Japan, given the high incidence of that cancer in this country, but for esophageal cancer, there is not established way that is proven to be cost effective. But there is something called Barrett's esophagus that the technical term is a metaplasia. It's a change in the architecture of the epithelium of the esophagus, especially distally at the GE junction. The GE junction is the gastroesophageal junction. It's that spot of that line where the squamous epithelium of the esophagus that has several layers of cells to protect from the acid changes to a more similar epithelium to the one seen in the stomach and bowel. That's what a Barrett's esophagus is, and it usually looks like this. It's usually called a salmon color mucosa change. For instance, in here, let's see. Oh, no, this is not the one. There. So this is the normal. It looks pink, and this is Barrett's esophagus, okay? Sometimes can be a little, what they call a tongue or salmon color mucosa, but sometimes goes several centimeters up. So that's what Barrett's esophagus is. And why is that important? Because it's probably the only proven precursor of cancer, of esophageal cancer, that you can act on to try to prevent esophageal cancer. Still, as I said before, there are not guidelines for a screening of the general population for esophageal cancer, but there are guidelines for surveillance of Barrett's esophagus. And in this case, surveillance and screening is because you don't suspect that the population has anything. We call it surveillance for Barrett's because it's based on the diagnosis of Barrett's that you then follow up. And now, if I have GERD, should I have an EGD to screen? There are some called signs or symptoms of alarm. For instance, if the patient is male of more than 60 years of age with chronic GERD, that is an indication for an EGD to rule out Barrett's, but also other signs of alarm like dysphagia, bleeding, anemia, recurrent vomiting. Those are indications for a patient without a diagnosis of Barrett's to get an EGD. Now, if you have Barrett's, then there are several guidelines for the surveillance. If you only have Barrett's, because from Barrett's, it is believed that esophageal adenocarcinoma, which is the most common in the Western world, goes from Barrett's esophagus to dysplasia to cancer. Something similar to what happens in colon cancer with polyps to high-grade dysplasia to cancer. There is something similar in esophagus, although it hasn't been proven if it follows this strict pattern of Barrett's, low-grade dysplasia, high-grade dysplasia, cancer. It's not proven. It has been seen that goes from Barrett's to some degree of dysplasia to cancer, but not necessarily following this strict pattern. So if you have Barrett's, you should undergo surveillance. And usually the surveillance is it's done by gastroenterologists. They do biopsies in 4 quadrants of the area of Barrett's, 1 centimeter apart. And depending if in that first time they find dysplasia or not, that may change the management. That from there becomes a little bit more intricate, so what to do. If there is low-grade dysplasia, nowadays the recommendation would be to ablate the area of Barrett's, like eliminate it with different ways, or to do EGDs every 6 months to a year, as it says in here. So that's really the only way we have to try to detect esophageal cancer in an early stage. After you're diagnosed with esophageal cancer, it becomes a little bit more complicated. You have, as in any other cancer, you have the diagnosis, tissue diagnosis. The next step is staging. Staging becomes a little complex, and to be honest, I think thoracic surgeons are central in this kind of management because we can see the whole picture of the patient and provide the diagnosis, what should be the next step in the staging, because not all procedures for staging are necessary, depending on the treatment, depending on whether the patient is going to have surgery or not. So the thoracic surgeon plays a central role in the management, even if the patient is not a candidate for esophageal surgery. And the treatment, it depends on the stage. It's usually a combination of chemo or systemic therapy. Nowadays, systemic therapy is chemo plus minus targeted therapy or immunotherapy, radiation, and surgery. There are a subset of patients that have very early stage that can be treated endoscopically, but that's an extreme minority, a very low number of patients. As I said, those patients present without symptoms, so it's those that are found incidentally. They have an EGD for whatever reason, not suspecting this. They have a little nodule. It's an early stage. You can treat it endoscopically. But most patients we have that we see will have a combination of this treatment. It's what we call a multimodality approach to cancer, which is the standard of care for most types of cancer nowadays. Something very specific to esophageal cancer is the nutritional support before starting any treatment, because patients that have dysphagia, not only because of the cancer itself that promotes for different reasons the lack of appetite, but these patients can literally not eat because of a mechanical obstruction. So that's another reason why the thoracic surgeon is key to evaluate this patient from the beginning, because we can decide based on whether the patient is going to have surgery or not, based on the weight and what the treatment is, whether we put a feeding tube or not. And depending on the surgery, if he's going to have surgery, what kind of feeding tube. So that's an important aspect that is different in esophageal cancer to many other cancers, is the nutritional support pre, during, and after the treatment. Since I am a thoracic surgeon, I wanted to show really quick that the esophageal surgery, this is an extremely simplified picture that shows what an esophagectomy is, but basically we have to, if this is the tumor, in theory a tumor, we have to cut about 5 centimeters above, 5 centimeters below, and then with the stomach, we create what we call an esophagus or a gastric conduit that we connect to the esophagus. And of course, as you can imagine, this is a surgery that you have 2 cavities that you have to access, sometimes 3, because sometimes the connection is in the neck. But we do it here. And we do it robotically with minimal invasive, although it's a prolonged surgery, it's complex, and the rate of complication is not low. But it provides the best chance of cure for esophageal cancer, which is not very high. Prognosis, it depends on the stage. These are the numbers provided for by the American Cancer Society. Again, the problem with this number is that most patients are diagnosed either here and localized, or locally advanced or distant. This, to be honest, the way they present these numbers in here are a little misleading, because between localized and regional can be an overlap, but most of the patients present in a stage that is not resectable. Actually, from all comers in general, all comers with esophageal cancer, only 25% of them are resectable, and only 20 to 25% survive after 5 years. But there is hope. I think that you have, for people that treat cancer patients frequently, you have noticed this new, what I would call a revolution in the treatment of cancer, with all the molecular and immunotherapy treatments that there are nowadays. And some cancers that in the past were considered a death sentence, nowadays we're talking about 5-year survival even in lung cancer patients with stage 4, which was unheard of before. So as I tell patients, there is hope. These new treatments can be even like they call it a capsule, a time capsule, because they can bring you to another time where there might be another treatment. So there is always hope for this kind of pathologies. I wanted to, like my partner, Dr. Kashyap, did, more kind of introduce you guys to what a thoracic surgeon is, because many people don't understand why you're a thoracic surgeon. You don't touch the heart, but then you touch the esophagus. As Dr. Kashyap mentioned, we are cardiothoracic surgeons. We train cardiac and thoracic, but it has become so specialized that then most big centers in the country nowadays have cardiothoracic surgeons that are so specialized either in cardiac or in thoracic. We as thoracic surgeons, we treat a group of conditions like lung cancer, esophageal cancer, and all these other pathologies. Basically, any cancer in the thorax we treat. But there is also a good number, and related to esophageal cancer, like GERD and hiatal hernias, that are precursors of esophageal cancer, along with achalasia. We also treat those. Those are benign conditions, but are related to cancer as risk factors. We treat those too. So even though we're thoracic surgeons, we do a good amount of procedures in the esophagus, benign and malignant. That's it.
Okay, thank you. Very interesting talk. And for our last talk, we have a team. We have Heather Thaxton and Emma Gillum, and Heather Thaxton is a certified oncology nurse, has a long experience at CMC, was cancer research coordinator for 8 years, and is currently the survivorship program coordinator at the Cancer Center. And has also had a long experience at CMC with 7 years in oncology, 3 as an infusion nurse, and the last 4 as the colorectal nurse navigator. So I think they're going to tell us all about what nurse navigators do, among other things, right? Okay.
Hi, everyone. So this is, can you hear me?
I don't think it's on.
I don't think this is working.
No, hers isn't working.
Batteries there.
Okay.
I got it back.
Can you guys hear me? Okay. Hi, how's everyone tonight? Good, good. I see a lot of familiar faces here. Yep, thanks for being here tonight and giving up your time tonight to come here to hear us talk about our clinic at the Cancer Center. I'm going to talk about our patient resource room and some of the comprehensive assistant resources and education that we provide to our patients, support services-wise. A little bit about oncology nurse navigators. We're registered nurses that specialize in oncology who help patients and their families and caregivers when they come to see us navigate through the health system. And you all know that it's tough, you know, if you don't have someone to coordinate care and get them from one step to another. Some of the things that we work on in our roles, we overcome barriers to care, provide a lot of education pertaining, you know, to their diagnosis, connect them with resources that we have in our patient resource center. Just there to support and facilitate and help them make informed decisions through their treatment from the beginning to the end. Timely access to care is, of course, we all know is crucial and important that they get that timely access. And of course, providing them with psychosocial support throughout their cancer journey at the Cancer Center. Our team consists of multiple navigators. We have a head and neck nurse navigator, breast navigator, lung and esophageal nurse navigator. I'm the GI nurse navigator there at the Cancer Center, genitourinary nurse navigator, a hematologic malignancy navigator, 2 oral chemo navigators, and of course we have dietitian, social work, chaplain, service for spiritual support, and financial navigators, and a survivorship coordinator, which is Heather Thaxton, and our team lead there at the Cancer Center. Our process begins with our pretreatment clinic, and of course it's member of those care teams that I mentioned previously that consist of the nurse navigators and social worker, chaplains, spiritual support, dietitian, and financial navigators. At our pretreatment clinic, we begin this when we get a referral, actually a message in our electronic health record system from their new patient visit. The nurse navigators follow up with their patients pertaining to their diagnosis, and then we follow through. We schedule an appointment for the patients to come in and see us. We can either do that in person or over the phone based on, you know, barriers. A lot of patients have transportation as a huge barrier to care, so we try to accommodate that and make things a lot easier for them. So that's offered. Patients receive a lot of helpful education at that point in time. Again, trying to ensure all the diagnostics tests are done that's needed, scans before they actually start their treatment, their ports placed, labs collected, medications sent to their preferred pharmacies so they can pick all those medications up before they start, and telling them more about who to reach out to through their journey with us. We create a care plan for them that's personalized as well at that moment in time, and then we send them off to the clinic to start beginning their infusion. And at that point, they're also, informed that they can reach back to us at any time through their journey. So that's a little bit of what our process is there with the Patient Resource Center, and I'm going to hand you over to Heather Thaxton, our survivorship coordinator. Thank you.
Can you all hear me? Is my mic on? Okay. So we don't just want to stop at the beginning of somebody's cancer journey. We want to, we want our patients to thrive. So that's what I am. I'm the survivorship coordinator. And that begins at the day of diagnosis and lasts throughout the whole cancer continuum. We want to know that they're supported all the way through it. My role is to help patients transition into the role as survivor and a thriver, whether that means that they're done with all their treatments or they're put on maintenance therapy. We want them to know that we're still here and able to provide different services and support. So we offer a survivorship post-treatment clinic, and what this does is it helps provide the patient with a comprehensive survivorship care plan, so that in one document they have the treatments that they've been on, the surgeries they've had, the staging, their pathology, and then I can either do it by phone or in person and answer all their questions, make sure they're getting their preventative screenings, following with their family doctor, making sure they're getting their scans that the oncologist wants them to get. And we also provide that care plan to their PCP so that everybody is on the same page and we're coordinating their care. It also helps to reduce their anxiety about the future and offer emotional support, because just because you've stopped treatment or on maintenance therapy, your whole world has changed, and you want to know that we are still there to provide that support. We also offer several behavioral health services. We have our psychologist, Dr. Citran, and we want to empower cancer patients through science and support and strength. Why does this matter? Why does behavioral health matter? Well, with the cancer diagnosis comes the stress and the anxiety and the depression, and the patient wanting to stay strong but may not being able to talk to the family because they don't want to worry their family. So we help them with that and cope with that to build resilience and hope, and hopefully to improve their overall health outcomes. We offer several different tools. We're doing genocyte psychogenetic testing, and what that is where you a swab of your cheek to test, and you send it off. They meet with our PA that works with our psychologist to see what is there medication out there and which medication helps them the most, as in antidepressants and medication like that. So it's really tailored to the patient, so that's really great. We've just started that here recently, so it's a really great tool. We have psychotherapy sessions, whether they be one-on-one, small groups. They talk to our licensed psychologists and work through the tough emotions, relationships, and life changes. The other thing is, they can have private sessions. They can come for treatment and have her sit while they get treatment. She can come over and talk to them while they're getting treatment. We also have family counseling because the whole family is affected by this diagnosis, not just the patient. We have monthly integrated medical group visits. So right now we currently have a breast support group that we are bringing experts in on nutrition, sexual health, exercise, stuff like that, relaxation techniques, pain management, so that hopefully it will help them with their cancer journey. We're getting ready to start, and we have a grant, the Survivor Peer Support Group, because who knows better than another cancer survivor what you're going through. So they're going to be able to come and sit with the patient, talk with the patient during chemo or in a private session or in a group setting. So we're really excited about this, and hopefully it will help build our, build people's confidence in what they're going through. Coming soon is a cancer exercise program. It'll have light cardio and strength building routines, music, movement, and motivation, group bonding, mood boosting, and once we get our certified nurses to get their certification, we're going to have it on Tuesdays and Thursdays from 4 to 5 at the Cancer Center, and then they also have a class similar to this at the YMCA on Wednesdays. And how it all comes together. We all work hand in hand, and that's really important. We work with the oncologists, behavioral health, the nurse navigators, clinic nurses, chemo nurses, and that's really to support the whole person, the mind, the body, the spirit, and patients feel better when we all come together to plan their care. And then this is my wonderful team at CMC Cancer Center. This is the care team. We are located at the Cancer Center. As soon as you open the big double doors, we're to the left. We're the resource room, and you don't have to have an appointment to come in. Anybody's more than welcome. We also have our social worker, a dietitian that can always be of help as well, financial navigators. So it's not just nurses, we are a whole team. So, and that's all I got. Is that okay?
Okay, thank you. It's just amazing for someone who's been at CMC since 1987 that, I think we didn't have anything remotely that comprehensive for so long. It's really great to see it. Okay, so I think we're at the last stage, which is a panel, and Jay, we're going to hand out our question cards.
I think we just did. So if you have questions, put them on the index cards and we'll give them up to Dr. Williams.
Okay, and I think we'd like our panelists to sit up on the chairs with the microphones there. All 4 panelists, please. Yep. He's on the phone here, but you can bring food with you if you'd like. Okay. Well, we'll give people a little moment. I have some questions of my own too. We'll see if we don't have time. I'll ask them.
Usually our navigators have some interesting stories or something about a patient that if you feel like you want to share with us, I love hearing those kind of stories.
Okay, great.
My light's not turning green. Okay. So one of our stories is that we've recently lost this patient, but we had a 30-year-old breast cancer patient who has no child care. And one of the services that we provided her is we helped take care of her little girl while she got treatment. And she really became like our little mascot. And our social worker was wonderful in trying to get her, financial help. And we kind of we adopted her really, and we bought Christmas and we bought birthday. And sadly, she has passed away this May, but that was her barrier. She had absolutely no family to help her with child care. It was either we help her or she wasn't going to get her treatment. So that's one that sticks with me.
Very nice. Okay, I think people are still writing questions, but we can start here. So these are 2 questions. Maybe actually 3 maybe. First is vaping. Is vaping a risk for lung cancer? and or esophageal cancer? And the other question is, does H. pylori increase your risk of esophageal cancer?
Yeah, I'll take it, I guess. It's a great question. Vaping directly, is it related? Without the nicotine content, and it's not directly proven to be related. It's more proven to cause a more chemical pneumonitis, and that's sometimes more dangerous than the long-term risk of cancer. And currently, the population that's vaping is the population that's younger and younger. And I think that's a very good question. The long-term results of vaping is still not known. When I was a surgical resident, even at that time, they were trying to find out the early effects of vaping directly related to lung cancer, and there's no direct correlation, but it definitely has a lot of detrimental effect on lung health. If you want to take the other.
Yeah, the most important part to say is that we don't have time enough yet. As you know, the lung cancer increase correlated the increase in the smoking rates, and 15, 20 years later, we saw the increase in the lung cancer. So we don't know yet about the vaping. Definitely, it causes an immediate damage as a chemical pneumonitis. Does it cause lung cancer, gastric cancer, esophageal cancer? We don't know yet. But if you keep vaping, maybe we will find out.
I'm just wondering about that. They started promoting vaping as a help people stop smoking, but from what I've read, a lot of really young people start vaping and it's then transition to smoking. So maybe starting vaping will increase your risk of these cancers just because you're more likely to become a smoker if you vape. I don't know. Does anyone have any thoughts on that? No? Okay. So
I think there was also a question on the H. pylori going there, right? So does H. pylori
yes.
directly cause esophageal cancer? It's not. Human HPV causes more of the squamous cell carcinoma, which is more upper esophageal type of cancer. H. pylori is related, however, to gastroesophageal reflux disease, and that leads to the changes that we know that may or may not lead to esophageal cancer, like Dr. Herrera said. So it's not a direct correlation, but it definitely is directly related to increase in the type of gastritis and gastroesophageal reflux disease, yes.
okay. Next question. For Barrett's esophagus, is there any preventable treatment going on that they are studying to prevent it turning into cancer?
There are some thoughts about stopping, some contradictory data showing some decrease if you undergo aggressive treatment or even with surgery to prevent GERD. But that is to kind of prevent the progression. But definitely for Barrett's, especially if there is low-grade dysplasia, there is something called ablation, which is basically eliminating that area or burning either with current, which is radiofrequency ablation, or freezing it and kind of killing that lining of cells is what is recommended for those patients. Regarding the regression of Barrett's, or with therapies that are non-ablative, there is contradictory data. Some data have shown that, yeah, there is some decrease in the progression of Barrett's if you have anti-reflux surgery. Some others haven't shown that. So it's hard for me to tell yes or no regarding that. But for Barrett's with low-grade dysplasia, at least the recommendation is ablation. If it's just Barrett's without dysplasia, probably only surveillance. You want to add to that?
Yeah, that's a very good and interesting question, because that's something that as thoracic and upper GI surgeons we discuss, and that's one of those things that we still don't know. There's definitely, no one can say that doing anti-reflux surgery is going to decrease your risk of esophageal cancer from Barrett's, because it definitely causes some regression of the Barrett's. There is evidence to say that it may slow the progression of Barrett's, but it is not going to take away the risk of esophageal cancer that you already had once you develop the Barrett's. So you still, even if you have anti-reflux surgery, you need to be on the surveillance protocol for Barrett's.
If a patient is interested in hiatal hernia surgery because they have symptoms of reflux, is that something you might discuss with them, other than just relieving their symptoms, that it might possibly decrease their risk of esophageal carcinoma? Would you ever mention that to a patient?
A lot of patients ask us that. I think it's a very common question and a good question to ask. I would be wrong if I say I know that I would decrease the risk of esophageal cancer by doing a hiatal hernia surgery. So because there's no direct correlation to saying that I would decrease their reflux by doing the surgery, I would decrease their chance of progression of their reflux esophagitis, which may reduce the chance of it progressing to Barrett's, which has a risk of developing esophageal cancer. We would never recommend hiatal hernia surgery as a reversal surgery for the risk of esophageal cancer. Does it make sense?
Is everyone hearing back there? Are the mics good for the card? Thank you.
And regarding the hiatal hernia, hiatal hernia has a list of indications for surgery, and prevention of esophageal cancer is no one. So I wouldn't mention that. As Dr. Kashyap said, I cannot tell. I don't have the proof. In theory, maybe. But the other problem is that the amount of patients with GERD or gastroesophageal reflux, whether or not with esophageal cancer, is so big as compared to those that develop cancer, that it's very hard to have a study that shows that difference, because it's extremely low. Even with Barrett's, Barrett's esophagus without dysplasia increases the chance of having esophageal cancer 30 times, but it's still 0.4% of the people with Barrett's that develop esophageal cancer. So when you have such a big incidence of a risk factor like GERD with a very low incidence, it's very difficult to prove that. So in the short answer is probably we cannot tell. There is another indication. There are many other indications for hiatal hernias, and prevention of esophageal cancer is no one.
Okay. Great. Here's an interesting question. It says, curious if you are familiar with electronic nose technology, what your thoughts are, and if it could be the next big thing in lung and esophageal cancer detection. Is this referring to like a machine that can tell the little molecules in the air? And I guess I'll add this, is I know there's some places where they've trained dogs to smell different kinds of cancers, and they find that sometimes the dogs can detect cancers on an early stage just by the odor of the person. Any thoughts on electronic or non-electronic nose technology?
I would. I don't know about specifically what they were referring to. I'm sure there are different ideas, and I'm sure there is something that's going to be in the not so far future where we maybe don't have to do an actual CT scan to find the early stage lung cancer. It's probably going to be a combination of things. Breath analyzers are definitely in the realm of possibility. There are studies going on to analyze the breath either with or without a challenge of a molecule to find out if you have lung cancer, or at least a suggestion. It's hard. There is also a blood test in which they try to find out based on not exactly the cancer shedding, but they're shedding small particles like proteasomes that can be found in the blood at an early stage, where they can try to combine that with screening and find out if you are at a higher risk of having cancer. There's a study called Notify, which we actually can order here, in which they test the blood, and that is used along with the lung nodule to assess what the risk of lung cancer is going to be. So those are the things that at least I know of.
But I think you mentioned that the only proven test right now is a low-dose CT scan. Is that correct?
Yeah, absolutely.
Okay.
That's the only proven, and over the last 10 years, and that stood the test of time and has reversed the curve. It mirrors mammogram. Like we say, it's the mammogram for the lung. But it's in terms of the impact that it's had, it's actually higher. But the one point that was in my presentation, but somehow it didn't make it to the final one, was if, let's say, in the country, if 100 people would qualify for lung cancer screening, if you had to take a guess in one of the best states, how many people in the last year actually had that screening, what would be a guess? And then we can ask what would be the guess for West Virginia. If 100 people would qualify for screening, you think how many people had their screening last year? Like 80%, 70%, 50, lower, 40? 20, yeah, 20 would have been great because overall, the best statistic we have is close to 16% in one of the southern states. But it started off at 5% in the 4 years, and then it's come up to 13% nationally. And in West Virginia, it's kind of close. It ranges between 10 to 13, depending on what study you see and what statistic you use. But if 100 people right now qualify for screening, not even 20 of them are actually getting screened. So that is definitely a barrier in which word of mouth, friends, and people can actually help improve that number.
Okay. Here's a question. When you see malignant cells in the pleural fluid, how advanced is the cancer? For example, what stage is it?
What cancer?
This just says cancer, but I guess...
Well,
we've seen carcinoma cells.
We're talking about like lung cancer?
At what that point, if it's into the fluid, how advanced is it?
most likely it's a stage 4. I mean, most of the time that represents stage 4, except if it is mesothelioma, which is a cancer of the pleural lining of the lining of the inside of the chest, but which is not very common. But if it's any other cancer, pleural malignant cells or malignant cells in the pleural fluid equals stage 4.
Which is the worst, right?
Yeah, it's metastatic disease.
Okay. Here's a question. You're talking about the rules for getting the CT screening, low-dose CT that you had to have, that so many pack years and smoke for so many years. Is there any role for doing this screening for passive smokers? For example, someone whose spouse was a 3-pack-a-day smoker and they lived in the same house for them for 30 years?
That's such a good question, and especially really important to answer in West Virginia and states that have such a high rate of smoking, where the household may not smoke, but insurance is not going to cover it right now. But that's something that through a primary care provider, Tennessee has a program where you can pay $60 to get a scan, like how they advertise for the heart, like the calcium scan. But right now, we are trying very hard to even get smokers who have quit, who've quit beyond that 15-year mark. They also are not covered in that criteria. So we're trying to work really hard with advocacy. A lot of groups are trying to change and bring change to that criteria so more people can be eligible. And when the reason that brought this up, apart from passive smoking, was also, a study in which they took a large group of patients who had lung cancer and saw if they would have qualified for lung cancer screening in that year. More than 50% of them actually did not qualify because they had stopped smoking 15 years ago. So, there is a lot of discrepancy in the criteria versus who actually needs to be screened. So passive smoking is something that comes up in the advocacy committees, but it's definitely not that I can say right now.
So do you think maybe the criteria for doing the screening should be expanded?
It should be expanded, absolutely expanded. That would probably be the best way to capture more people, also get them be adherent to the screening is the other big challenge that we have, as well as, get this covered more widely by insurance, because I don't think anyone would want to pay yearly to do this scan. Yeah.
Now, you mentioned that with the low-dose scan for nodules, you're going to be able to get the cardiac calcium score. Does it go the other way around? If you get the cardiac calcium CT, are you going to get a screening for lung nodules?
That's such an excellent question. So let's talk about the second part first. So that's where the incidental lung nodule program that I mentioned in the end comes into play, where cardiac CTs are usually done in patients who are also at high risk for lung cancer. So of all the cardiac CTs, that has the highest incidence of catching the incidental pulmonary nodules, which get diagnosed as lung cancer. So it is important to, from the CTs that get read, those nodules get appropriately managed through pathways where people look at it, and because the cardiologists usually don't want to take care of the lung nodules, and they send it back to the primary care provider, who is also many times they want it off their hands and someone else to take care of it. That's what we want to bring. And the other way around is harder, but there are pathways to do that. One of the things that makes it hard is there is a particular protocol that of the scan that needs to happen. Like it needs to be either cardiac gated or with a certain amount of cuts that we can get an accurate calcium score. Mm-hmm. But we know that the most common action item that happens after finding a result on the calcium score is to get either a cardiology visit, which results in starting of a statin. And that is a really important part of preventive care for diagnosing coronary artery disease. However, right now we are not able to directly get the calcium score, but estimated calcium score, which is very close, we want to get it. And Dr. Reinhardt and Dr. Ely and our group is working to develop an algorithm that in our screening site we have a pilot plan that we can get the calcium score.
Wonderful.
So we'll see how it works out.
Now, I don't think it is, because there are two things. For the coronary calcium score, is a more in detail, but a smaller portion of the thorax that is imaged. So you find a nodule there, definitely there is a nodule. But the low-dose cancer screening that shows all the thorax to show any nodule, you don't have the level of detail that you need for the calcium score. Mm-hmm. So ideally, that a good idea that actually Dr. Kashyap had of combining both would probably entail something where for the calcium score, you include more of the thorax and to be able to combine it.
So maybe you need to have a double the double test, the
Yeah.
screening
and
slash calcium. CT.
It is, getting that combination. The biggest thing that happens with, screening is we are trying to capture that patient population that says they don't really go to the doctors or they don't want to go to the doctors. It's not like they're not interested in taking care of their health. They don't have that one push or that one momentum that needs to get them there. And once we capture them, they're able to keep up. So that initial capture and as well as the nudge from a provider is what we found is the biggest barrier.
Okay. I have a question for the nurse navigators. Is there a role for palliative care consultation in your process?
So currently, we're actually, palliative care is getting ready to start their own program at the Cancer Center, and we're actually be doing a build out to work hand in hand with them. Right now, we do not have anybody from palliative care, but we, our social worker can consult palliative care. We can, the nurses can get with palliative care. But yes, that is a definite need, and it's we currently are working on it and actually have plans on starting the build out in January for them to come over.
Yeah, that'll be great. Because from my understanding of the palliative care legion, whenever someone has a major diagnosis, regardless of their prognosis, they need to have a palliative care consultation for planning. Even if it's you anticipate a good outcome. So okay, that's great. And are there any more cards out there? Doing good cards? Okay, well, so I've got one more, which is not really a card, it was a comment. I thought it'd be a great, I'm saving it because it's a good one to finish on. So just a comment. I'm glad that there is new hope for cancer treatment. 2 of my colleagues were recently diagnosed with stage 4 breast cancer. Thank you for this meeting. And I'd like to add that as someone who's sort of at the very end of my medical career, I was telling my friends just this afternoon, I'm less concerned about how it's going to affect me as a professional and more about how it's going to affect me as a patient. And I feel much relieved as a potential patient that we have so many good services here that it's just amazing compared to what we had a few years ago, just so much in advance. So thank you very much for our 4 panelists, and thank you to the audience for coming. Anything else, Jay?
Turn in your evaluations to me, and I have a diploma for you to pick up on your way out.
Okay. Thank you very much.